Shrug family, this week on Barbell Shrugged, Dr. Mitch Reiter is coming on the podcast, and he is a spine surgeon up in New Jersey and also has a very cool company that is testing for heavy metals called Sensiband. And if you have any surgeries or scheduled for any surgeries, I highly recommend listening to this show so you can understand preparation, recovery, and if there are any irritations or potential allergies that you have to heavy metals, there's a big deep dive into that and how you can arm yourself, advocate for yourself before that surgery. As always, friends, make sure you get over to rapidhealthreport.com. That is where Dan Garner and Dr. Andy Galpin are doing a free lab, lifestyle, and performance analysis, and you can access that free report over at rapidhealthreport.com. Friends, let's get into the show. Welcome to Barbell Shrugged. I'm Anders Warner. Doug Larson, Dr. Mitch Reiter. Guys, this happened in real life. We shook hands. That's incredible in 2025. I was just telling a story. I was asking my kids the other day what they thought I did, and my son, my now 4-year-old, goes, "You talk to the computer." And I went, "Thanks. That's great. That's how he looks up to me. Your dad's a real hero, just yelling at this screen here." So we got to shake hands in New Jersey, and that is special. This is actually how we met through a couple mutual friends. And then I'm excited to dig in. You're a spine surgeon up in New Jersey. And first off, that seems like a very complex thing. Anytime the spine is involved, seems very, very important to, one, have that working, two, surgery around that area. If I have too much coffee, I disqualify myself for that. So I'd love to dig in just on a little bit of like, how did spine surgeon come to be?
Yeah, no, that's a great question. It's stressful. I wasn't fully warned about the magnitude of that, but I'm one of those guys that always wanted to be a doctor. Since I was a little kid, I did a 6-year combined like college med school program, so I kind of always knew where I was heading. Did 5 years of orthopedic residency. And during that, I started to see spine surgery. Did another fellowship after that, really getting into spine surgery. And what always impressed me is in carefully selected patients, they just do so well. Like they'll wake up in the recovery room and say, "Thank you." You just cut a hole in them and they're thanking you because the shooting, burning pain down their arm or leg is gone.
Yeah.
So it really does work great in properly selected patients. That's the key. That's what got me into it. When you first see that miracle, you're like, "Oh my God, I want to be part of that."
Yeah. When you look at the spine, though, I would imagine you're not working on the whole spine. Are you more cervical, thoracic, lumbar? Like what is your specialty?
Yeah, no, that's a great question. So within spine, some of the specialties are like deformity. People that are high degree, severe scoliosis. I'll do scoliosis in adults. I don't do that much pediatric scoliosis anymore. But I do the whole spine. I'm not, most of us don't super subspecialize. I do a lot of cervical disc replacement. So nowadays, a lot of things are about motion preservation, minimally invasive surgeries. Everything's, we used to set off a nuclear bomb and say, we got it. We realized that wasn't the best answer. So we really now are just highly focused on minimizing collateral damage. So I do lumbar, cervical. Thoracic is less common. Just not that much surgery is needed in that area. But but I'm a sort of a broad-based generalist in spine.
Yeah, we talked about this in New York. When you say minimally invasive, you just hit like all the bullet points because my wife is also on the product side of cervical spine things. You hit all the touch points. That's what I've been listening to for the last 14 years of my life.
There you go. Now you're
Minimally
ready.
invasive. Like, I'd love to dig in because there's some of these surgeries that I did not realize how crazy. Like, I always think the spine being like, it's the back of your body. And if you're going to have surgery there would be some sort of sometimes I learned, and this is probably like, I hope it's not all the time. Sometimes you have to go through people's throat to get to the back of their spine.
Yeah, a lot of the time. And it's actually easier on the patient because everything up here is soft and moves out of the way. And if you look, your spine is actually in the center of your body. That's why it works sort of to hold you up. Otherwise, you'd be constantly fighting, falling forward. So going from the front, there's very good planes between the tissues. So we don't go through your throat, but we move everything over. And the recovery's so easy and nice for the patients because you're not disrupting all these muscles and ligaments in the back. And the same thing in the lumbar spine. We'll sometimes go from the front because your abdominal contents are squishy. They move out of the way. we can really do a much better job reconstructing things biomechanically, restoring height to discs, stabilizing, putting in
Yeah.
artificial discs, all from the front. So at first, even my residents will say, "Oh my God, it's so close," when they see the spine, it's like right there from the front. But it does work quite well going in that direction.
Hmm.
That's so wild to me. Uh, yeah, I would have not realized that. I'd love to kind of dig in. You mentioned kind of like the qualifications of your patients. And when does somebody actually know that like surgery is the next step? Because we all kind of know that almost everybody is going to have some sort of back pain in their life. And when does that go from like a movement issue that a trainer could help with, or like inflammation, to dry needling, to chiropractic, to now I'm in your office saying I need surgery to actually go fix this structural problem?
Yeah, no, that's a great question. I'm clearly the last step in a
Yeah.
long line of other things. So most back and neck problems, get better. So it's just with some time or some anti-inflammatory medicines.
Hmm.
Physical therapy is quite critical. The key is getting your biomechanics established, making sure your core is strong, you have your proper flexibility. There's a lot that goes into that. So everyone starts with, let's get you into good therapy, have somebody qualified take a look at you. If you have a great trainer, they can do it too. We use some medications to sort of mitigate the pain while you're trying to get your body to heal and rehab. Step two, start into the imaging, x-rays and MRIs, and then there's some interventional pain management procedures that can sometimes, block people's pain and get them back on the recovery course. And then I'm the last step. And it's always a balance. If somebody has a big mess of a problem that needs a huge surgery, we try hard to avoid that. But if somebody has a smaller problem that's a soundbite that I can fix and get them right back on track,
Hmm.
some people choose to do that. They don't want to wait a year.
Yeah.
They want to get back to athletics and sport. So it's
Hmm.
balancing risks, benefits. You're looking at your patient, what's their overall health, what are their goals.
Yeah.
But yeah, I'm the last step in a long line of prior treatments. So you really want to exhaust all that. And you have to be your own advocate. I don't want to sound jaded, but there are some surgeons that are pretty aggressive. So, if you go into some surgeons' offices, you're going to get told you need surgery, but really make sure you've tried hard to avoid it. And you probably do your favor getting a second opinion, making sure people agree, with what's being recommended.
Yeah,
Hmm.
it's probably like the reverse, whatever methodologies you've used to mitigate the idea of having to have surgery. Once you get to that part of the pyramid, then it's walking yourself back down from the surgeon to the physical therapist to the trainer to the chiropractic. Like you want to like once you are injured, step by step get to you, and then step by step also coming back to being your best self. I would imagine is kind of how you work with things on the outpatient side as well.
Yeah, of course. And surgery is best at sort of undoing mechanical problems like pinched nerves, or
Yeah,
instability.
Hmm.
Um, Surgery for just degenerative problems, arthritis, that's really it's not a great option. We try hard not to do it. I don't want to say never, but we're particularly good at when you have a very focused problem. There's a mechanical instability or what's called stenosis, where nerves are being pinched. Those patients are so happy. A lot of them wish they'd done it a little sooner because they gave up years sometimes living around it. But you don't want to have surgery just because you have an aching back. You want to really have
yeah,
a specific problem.
So an acute injury, specifically for our audience, like weightlifters, powerlifters, CrossFitters, bodybuilders, people that do a lot of heavy lifting, like rounding your back on a deadlift as an example, is just like a very common, obvious no-no in our industry because you'll slip a disc. What exactly is happening there, and to what degree can physical therapy actually fix that if it's gone too far versus surgery becoming 100% necessary?
Yeah, no, I do see a lot of lifters. So, the disc is the cushion between the bones in your spine, and it's shaped like a jelly donut. And what a slip disc really is when you tear the outer part of that jelly donut, it's called the annulus, and then some of the jelly squeezes out, and it pushes right up against the nerve, the beginning of the sciatic nerve. So you get that shooting pain down your leg. So that's called a herniated disc, and your body can reabsorb that. And most people, your body will reabsorb that. So if you get a severe back pain followed by shooting pain down your leg and numbness or weakness, that's almost always a herniated disc, and I see it a lot with bad form. I used to see it when kettlebell swings were the rage. If you
Mm-hmm.
don't do them just right, I used to see that. And you still start with therapy and medications, and sometimes your body will reabsorb that piece of disc that's come out and heal
yeah,
the hole in the disc. But when they don't, that's when we do a microsurgery, where I go in there under magnification, fiber optic lights, and just, do a small cut, go home the same day, remove that fragment that's pinching the nerve, and those patients are so happy. So it's a very good surgery, but a lot of people don't need it. So you start with the less invasive, and if you don't get better, we fix it.
Mm. Well, you said it can be reabsorbed. Like, to what degree, after it's reabsorbed, can it just come right back out? Does the tear or the hole actually heal up, or is the hole kind of still there, and like the pathway out is now the door is open, so to speak?
You seem like you know your stuff. So that hole heals. It's never quite as strong as a perfect disc, whether you have surgery or not. And there's something called a recurrent disc herniation. So it can re-tear, but that rate is low. It's 7% or so, depending on how the type of tear. If you have a huge, like if you have like a blowout of a tire, picture of it, it's much more likely that that doesn't heal as well as opposed to you get a little fissure and a piece squeezes out. So
Mm.
depending on the size of the disruption, the size of the herniation, there's a rate of recurrent disc herniation. But what they've shown is you can't really hide from that. You want to be active. You want to use your back is like your heart. You don't ever say, "Hey, lay down, don't waste those heartbeats." You kind of want to use your spine. So we get people back to full everything. Maybe the only time the recurrence rate is higher is in like professional football, maybe very violent contact sports.
Mm.
But lifting, other things like that, they don't raise the recurrent disc herniation rate.
Yeah. I mean, specific to weightlifters who are in hyperextension a lot, they end up getting spondylolisthesis and like similar issues like that. Do you do surgery for those procedures, or is that more of a PT thing?
Well, so spondylolisthesis, there's two types of spondylolisthesis. One, the type you see in weightlifters, especially when they start in adolescence, is it's from a stress fracture in the back, which is called a spondylolysis. A stress fracture means it's broken, but it's like when you take a paper clip and just wiggle it a million times and it cracks. When
Mm.
that happens, when the bone cracks, it can then shift out of place, and that's the spondylolisthesis.
Mm.
Most time they get better with rehab, but sometimes they do have to do a surgery for that. And those patients, they're back to, deadlifting and everything once it's healed up. So they get back to everything.
Mm.
But most people don't need that surgery. Usually you can rehab through it. I have some like level 10 gymnasts with spondylolisthesis, that are, doing, crazy stuff. But there's a group that need to be fixed. And when I fix them, they're very happy. They get back to everything.
Dr. Andy Galpin here. As a listener of the show, you've probably heard us talking about the Reiter program, which we're all incredibly proud of. It's a culmination of everything Dan Garner and I have learned over more than 2 decades of working with some of the world's most elite performers, award-winning athletes, billionaires, musicians, executives, and frankly, anyone who just wanted to be at their absolute best. Reiter is not a normal coaching program. It's not just macros and a workout plan. It's not physique transformation and pre and post pictures. Reiter is something completely different. Reiter is incredibly comprehensive and designed to uncover your unique molecular signature, find your performance anchors, and solve them permanently. You'll be working with not one person, but rather a full team of elite professionals, each with their own special expertise to maximize precision, accuracy, and effectiveness of your analysis and optimization plan. Reiter isn't about treating symptoms or quick fixes. It's about unlocking your full potential and looking, feeling, and performing at your absolute best, physically and mentally, when the stakes are the highest. To learn more, visit aretelab.com. That's ARETE lab.com. Now, back to the show.
Yeah. Yeah, go ahead, Doug. Sorry. I was going to say, specific to me, I've done a lot of jujitsu in my life, and the guys we were hanging out with in New Jersey, buddies of yours, they also do a lot of jujitsu. Neck problems are especially prominent in jujitsu. You're being guillotined, you're being choked, you're being collar tied, and there's just a lot of wear and tear on the head and neck. And I've had chronic neck pain now for 15 years. Never warranting surgery, in my opinion, but it's just kind of always there. So in a selfish way, like, when should I start looking into surgery, if ever? For like the kind of like the gapping that I have felt with someone just tearing on my head, trying to choke me, and I can feel my spine kind of pulling apart at times.
Yeah, that's a great question. If you're not having shooting pain down your arms, I would try hard to rehab. I would see an actual therapist because there are certain physical therapy things, repositioning your head. It's called chin tucks. There's certain ways to take some strain off those discs, improve your flexibility. And then if it's really bad, you may at least want to see somebody. You get an MRI, know what you're up against. If there's one bad disc, I have I'm a secondary black belt, so I've done disc replacement surgery in some jujitsu people, and they've been very happy. They're back to full contact. First I was a little worried because I was like, should I do a fusion, which is a more solid surgery but not as good for them.
Yeah.
But I have disc replacement people doing jujitsu, getting choked out, and everything's going well. So, there are options, but neck pain, we try hard to avoid surgery. When you start getting nerve pain, we lean more towards surgery.
Hmm.
But years and years, if you've already tried rehab and tried everything, then I would at least see somebody get an MRI and just know what you're dealing with.
Yeah, very fortunately, I've not gotten any shooting pains. It's pretty localized. I seem to be hypermobile mid-cervical, and I do a lot of manual stability exercises, and that's helped a lot. And I just don't compete anymore, which is another part of it. Uh,
Yeah.
but yeah, it's always kind of on my mind of, am I ever going to need to have surgery on my neck at some point? Which of course I don't want to have if I don't have to.
Yeah, hopefully not. And but you want to, keep doing those exercises. I tell people just like diabetics have to watch what they eat, you have a neck issue. You got to set aside 5 or 10 minutes a day to keep your neck really extra solid and bulletproof that area.
Hmm.
Yeah. You mentioned earlier about kind of people having that instantaneous relief. Is uh, is it common to have reoccurring issues, or is this kind of, I would imagine it's your goal, but the reality of life is that a lot of people go back to the same bad habits or don't fix some of the movement issues or whatever that is. Um, when you see that people walk out healthy, are they typically coming back? Is it there, are there many people that have like the recurring issues, um, like
And
specific to spine?
yeah, so it's a multi-layered question. So our spines are segmental, meaning there's lots of different levels. So if you have a problem at L4-5, for example, in your lower back, the rest of your spine is still there. And even if I fix that level, there's a chance you're going to have trouble at another level. You're going to keep getting older, which is a good thing.
Yeah,
Um, and then we our goal is to not have you come back for problems at the same spot. But that being said, like we talked about with the disc herniation, we get the pressure off the nerve. People's job is to keep their core really strong, stay fit, and usually they never look back. We've tried with surgery to do what's called motion preservation, where we used to do what's called a fusion, where you remove motion from the spine and make things really solid. And they felt good, but the problem is that then puts stress above and below the fusion. You transfer that stress to the next levels, and you accelerate the wear and tear at those levels. We try nowadays to do less fusion, more, motion preservation surgery to reduce the risk of needing additional surgeries. But your spine keeps getting older. There are other spots, and there's things that can recur. So we deal with it. The other thing is when people just injure their back in general, we say that back and neck problems are episodic. Meaning you can be fine one day and then reach for a can of soda and your back go out and you're stuck on the ground. It's a Nobel Prize waiting to be won. They have some famous MRI studies where they have somebody with a baseline MRI for some chronic back pain. They re-MRI them when they can't even get out of bed because they, went to put their sock on, and there's no change. So, and they over a few days or a week, they usually reset to their baseline. So there's not something massive structural that happens, but back and neck problems can be episodic where you can, have a major flare up, and we just need to learn to rehab through that, use medications, and over time, if you get your back in great shape, that happens less often and they're not as severe, they don't last as long.
yeah. The when you said that many people have that like instantaneous feeling of relief, I it's very interesting how some body parts specifically, like my dad had a hip surgery, and they wanted him walking on it immediately that night, like walking out of the hospital or out of the office, essentially, like load it as much as hard, as fast as you can to like really start to like dig that new thing into your hip, and your shoulder and your hip are like relatively similar. But my mom had a shoulder replacement, and that was like 4 months of do not move your arm. It's in, are there different parts of the spine that take longer to heal, in that like some of them are more stable areas of the spine, some are built for more flexibility. Does it matter where, when it comes to kind of the recovery side of things, on how long people can expect to be dealing with any pain or issues?
Yeah, so it's very variable for different parts of the body. So first, before I go to spine, for example, in a shoulder surgery, you're reattaching ligaments and tendons.
Yeah,
Those reattachments are weak until they heal. So that's why motion is limited. You don't want to start firing muscles off and pulling, rotator cuff off.
yeah,
Hip replacement, it's really stabilized with cement. It's impacted in there. You want them up, and so every surgery has to be, tailored to, the exact, what was done and the patient. But in spine, the big push is for rapid mobilization. So we fix things strong enough so that you can get up and out of bed quickly because it is very bad for you to be stuck in bed
Yeah.
any longer than absolutely necessary. So nowadays, with implants and we can make things strong. We usually don't even need to use a brace, or some doctors like the brace as belt and suspenders, but we get people up and moving quickly, whether it's the neck or the lower back. So it's very rare to tell somebody they need to stay down.
While we were in New Jersey, you were talking about different types of metals with implants can cause problems within the body. I had some taste of this with my mom when she wears a necklace, like her skin will start to bubble up and like get all blotchy. And I never really thought too much about putting metal in your body from an implant or a joint replacement. But you talked about this extensively when we were in person. Can you dig into that a little bit?
Yeah, no, definitely. As you know, I have an invention related to that. So, allergies have become just more common. I have kids with nut allergies. We carry EpiPens. Gluten allergies are common. There's all kinds of autoimmune diseases. For whatever reason, we are all just our immune systems are more sensitized, and we're trying to figure out what's causing that, but it's a fact. And metal allergies are common. There's a lot of people that can't wear certain jewelry, or they'll react to a belt buckle or to a ring. And yet, despite that, surgeons are putting metal in people all the time, and almost nobody's getting tested. And that would be okay if all the results were great. But the problem is the results are not always great. Something
Mm.
like 30% of knee replacement patients have chronic issues, have a suboptimal outcome. Same thing with hip replacements or certain dental implants, sports procedures, any procedure where metal's put in your body. There's a subset of people that don't do great. And some of them we think might be a reaction to the metal that's in their body. And then actually in 2019, the head of the FDA even put out an alert saying we need to figure more out about this. People are having reactions to metals in
Mm.
their body. So that's triggered my interest. And then there's a long story that goes after that as to where it led me. But
Mm.
definitely some people react to metals. The metal allergies are
Yeah.
known. I mean, a lot of women will know they can't wear certain metal. Yeah, we're
Yeah,
putting it in them permanently.
when you were talking to us about it, it was one of those things to me where it was like, duh, this is like so obvious. Like in our lab testing that we do inside our program, like we test for heavy metals. We want those gone from people. And then you go and have surgery and you're like, how about this metal rod we're going to put on you? You're like, hold on a second. Wait a second. Like no one's testing me for, does this fit for me? Like, I, I guess like, what are the normal metals? Which ones are safer, broadly speaking? Um, what's kind of like the standard practice, and what are the options that people can have going in to have this conversation with their doctor?
Yeah, no, so the thing about the outcomes not being great, it turns out that the surgeons have options as to what they put in you. It's not just you get the exact same implant for everybody, and we want to figure out ahead of time what is the right implant for each person. And there's ways to test people now for metal allergies to see, hey, maybe nickel isn't right for you, or maybe cobalt is not good to go into your body. And medicine has changed, and people like you are helping wake people up that, we can't wait for problems and then go after them. We can't say, hey, now you have diabetes. That's the last step on your insulin axis going off for 20 years before all of a sudden you meet the criteria for
Yeah.
diabetes. So it's the same thing with surgery. We need to get the specifically the right implant for people. The most common metals that are put in people, stainless steel is an alloy of nickel and chromium and iron. Iron's okay because it's in our blood. Nobody reacts to iron, and sometimes there's a little cobalt in there. Titanium is an alloy of titanium, vanadium, aluminum. So joint replacements usually have nickel, cobalt, chrome, and molybdenum. So there's a lot of metals that get put in people, and most surgeons are just busy and they just aren't interested, and they don't want any barriers to getting people into surgery. They're just trying to move fast. And it's not a short conversation when you start asking people about metal allergies because a lot of them have them, or a lot of them know somebody who, hey, my aunt had a knee replacement and it went south.
Mm.
A few percentage of these things get loose, of implants get loose in people, and they call it aseptic loosening. And we don't know what's causing that, but we suspect allergies may be a part of that. We're not, they're getting loose for unknown reason.
Hmm. Wait, so what would be the mechanism there? If you have an allergy to a metal, how does it cause the implant or the replacement to loosen?
Yeah, so an allergy to a metal is called a type 4 hypersensitivity reaction. It's a T cell mediated reaction, and it leads to chronic inflammation. So a lot of people that have an implant will have pain at the site of the implant or inflammation or swelling. But some of them get more systemic symptoms. They just feel crappy. They're tired, achy, fatigued or headaches. And the surgeons a lot of times just write them off and say, hey, you have fibromyalgia. That's why you are achy and everything stinks, or it sucks to get old, or or they say you're depressed. There's a lot of answers to why people say I'm not doing great after I had this implant. But what's happening is they're having inflammation in their body. It's a T cell mediated type 4 hypersensitivity response. And it causes any type, causes inflammation, which is all those things, swelling, bone resorption, whatever inflammation causes.
Mhm. Yeah, I can see the swelling, especially. It's like if it swells, it's getting bigger and smaller over time, and then kind of just makes it looser and looser and looser. And then as it gets kind of more wiggly, we'll say, it just gets achier.
Yeah, and that's a smaller percentage of people. Some people don't get loose, but they just hurt. They're just like, hey, I have my knee replacement, it's still hurting. It's 5 years later, and it's aching and swelling. And if you find out, hey, you have a chrome allergy, it'd be nice to know that so that you don't get another knee replacement with chrome in it. That's kind of the concept behind what I've invented, a way of testing people, because what we want to do is make sure they get the right implant. The big companies make nickel-free implants. They make hypoallergenic implants. So while they don't like to talk about this problem, because they sell so many regular implants, they obviously know it's out there, and they've come up with solutions. The analogy I tell people is that I'm going to buy a house under a cell tower, and I said, well, listen, I called Verizon, I called AT&T, they said it's okay. I don't know how interested they are in actually knowing.
Sure.
So same thing with the implant companies. They're nice, but they're not looking for trouble, if you know what I mean.
Yeah. Yeah. You said something similar about other doctors, and you said something similar on the show just now about how they just want to move fast and get things done. If you can't be like directly blamed for something, then, not my fault, not my problem. But you mentioned in New Jersey that you've talked to other doctors about this, and they basically said, I don't think you really think it's a problem. And then you ask them like, well, if you knew somebody was allergic to nickel, would you put a nickel implant in their body? And they said, oh, no way, absolutely not. And you go, well, so it does matter. Like, you should test your patients for this, right?
No, you're exactly right.
Don't
I'm always flabbergasted because they say, I don't think it's a really big problem. And there's some data that tries to say that it's not a big problem. Because if you just look at what's the failure rate of knee replacements, they're going to say it's equal. It's not failure. You got to look at nuances, But
Yeah.
but then I said, well, if they come up to you and say, I'm allergic to nickel, well, then they're going to say, oh, I won't use nickel on you. So like you just said, they do care. They just don't want to scientifically gather that information prior to surgery.
Yeah.
So I don't know how they rationalize that in their mind, but nobody says, oh, you're nickel allergic, I still put nickel in you. I don't care.
Yeah. I mean, I had a shoulder surgery. I had a slap tear years ago and got it fixed, and it's better in many ways, but it still hurts on a regular basis. Like, not all the time, but sometimes it's achy, sometimes I get a sharp pain here and there. Like, I consider it to be a successful surgery, but it's definitely not what it used to be. And so if you get a replacement and your knee is still achy, maybe it's just a 2 out of 10 for the rest of your life on the achiness scale, it's a successful surgery, but also it'd be a lot better if it didn't ache.
Yeah, exactly. So the achiness might just be that's just the way it is, or it could be you're having a low grade response. The thing is, if it's easy to know that, it'd be nice to, and I'm not saying ever take that thing out unless it's really just a total failure, but for your next one, because a lot of people get one knee replaced and 5 years later they need their hip replaced or they need their shoulder done. It's nice to know, hey, nickel is not good for me. It's, I'd rather use, there's other options. So, let the surgeon know.
So if you've already had a joint replacement, or we also talked about dental implants as another way people get metal into their body, and you are experiencing some chronic achiness, you suspect maybe after hearing this show, you have a metal in you that is problematic for your body, and you're having some type of immune response to it, and the achiness or pain you're feeling is from an inflammatory response to the metal itself. Like, how do you test for it? And then after you test for it and you determine, hey, they put nickel in my body, I respond negatively to nickel, then do you go back to your doctor and say, hey, you guys put this metal in my body that my body is allergic to, or I'm having a reaction to, I want a new one? Or is it better to leave it in? There's downsides
so it's a layered question.
right?
So the way we test for metal allergies traditionally, before Sensiband that I'll talk about, is there's really two ways. One is called skin patch testing. That's the gold standard, where you go to an allergist and they put patches on your body, and you go back to the allergist 2 days later and they look at them, and sometimes they'll have you come back at 5 days to try and get a delayed look. So it's 3 visits.
Mhm.
It's really a metal salt in a petrolatum gel. There's adhesives. You can't exercise because you can't sweat under there. You can't swim. So it's inconvenient. It's expensive. It requires multiple doctor's visits, and it gives you skin data. And
Mhm.
then there's another test called lymphocyte transformation testing. It's very rarely done, but it's a blood test. It's expensive, and it's really not FDA approved for this, but it might be a really good test. As we're trying to learn more about that test, but it's rare, and like I said, not even FDA approved for it. So there was really we need for something better. So what I wanted to do, and my partner Mark Drzalo is a spine surgeon as well, we wanted to make a test that was convenient, didn't require a prescription. We wanted patients to learn what they were allergic to, empower them, and we wanted to make it cost effective so we could look at large populations of people, not wait till somebody's having the rare failure, then they go for the lymphocyte test. We want to look at everybody.
Mhm.
So SensiBand is a wearable device. You get a kit that contains multiple metals. Right now the kit has 7 metals, and you can wear them on your wrist like a watch, like a swatch, for 7 days, and you see if you get a delayed type hypersensitivity reaction. It's called a contact dermatitis, like a poison ivy type reaction. So if you get a reaction to the metal on your skin, then it gives you some information. So those are the three. Now we used to be only 2 tests. Now you have 3 tests that let you know if you're allergic. To get to the second part of your question is what do you do if you're having a poor outcome? So metal allergies are the Wild West. Like nobody fully understands them. So I'm
Yeah.
not saying that your doctor did malpractice or something crazy and they didn't test you. Like we're trying to get this out there. It's not really being done commonly yet. We're trying to change medicine just like you guys are, trying to get better testing ahead of time to make people healthier.
Mhm.
So if you go to the dentist and having a poor outcome from your implants, number one is if you get another implant and you're nickel allergic, they can do what's called a zirconium implant. It's a hypoallergenic, better implant. It's a little more expensive, but it's better. My partner insisted on zirconium implants in his mouth, for example.
Mhm.
Um, should you take out the old ones? I would not do that unless they're really failing. Because it's taking an implant out is a big deal. There's downsides to that. Now, that being said, there are cases where people have a metal allergy that's so bad that the implant is revised and they have a better outcome. But that is a big decision with risks that you need to discuss with your surgeon. It's not like a gimme, like get these things out. But it will let you know the next one that needs to be done should be done with the proper metal for you.
Mhm. Do you have any data or any insight into kind of what percentage of the population has these kind of issues? Is this like a 0.1% of the population, or is this like a 5% of the population? Where are these numbers in your mind?
Yeah, no, they're pretty high. So in Europe, they actually have something called the nickel initiative, where they're trying to use less nickel in all products because so many people are becoming nickel allergic. So in the United States, 20% of women are nickel allergic. So it's a high percentage. Men, it's lower. It's probably in the below 5%. Chromium is and cobalt are the next two metals, and they're in the sort of 1 to 3% range, so lower. And then it goes down from there. Titanium is pretty rare to be allergic to. Vanadium is very rare. But nickel, chrome, cobalt, they're up there. Not super high, but 20% for nickel is really high in women. So those are the sort of the four horsemen. Um,
Yeah.
so it's not 0.1%. It's higher than that, but it's not, half.
And then as far as implants go, like what are the most common metals for implants?
Yeah, that's great. So if you break a bone or have a sports procedure, usually they're using stainless steel, which is contains nickel and chrome, two of the worst offenders.
Hmm.
And there's a titanium option. And now titanium works just as well. Maybe it's a little more expensive, not even much. So if you're nickel allergic, you have a great alternative. So most broken bones and sports procedures are using a stainless steel implant. When you get into joint replacement, the metallurgy is more complex, and they're using cobalt, chrome, molybdenum. That's why we test for all of those. But there are hypoallergenic joint replacements. There's one that contains none of those. It's made of zirconium. But
Hmm.
most commonly, they make nickel-free joint replacements. Most big companies now have a nickel-free option since nickel is so much higher than all the other allergens.
Yeah.
So they're commonly put in people's body. In spine, we use titanium implants. And titanium is very hypoallergenic, not zero, but much lower. And we don't have a good alternative because in the spine, we use MRIs a lot. And MRIs, you can't have what's called a ferromagnetic material near where you're looking with the MRI. It creates a blur. It's not dangerous. It doesn't, go out of place or anything. You don't drag across the room, but it causes blurriness or artifact around it. So we try and use titanium implants.
Hmm.
So spine, we don't routinely test because we don't have a great alternative. And, the incidence is low. So in all of medicine, we're always looking at that. What is the incidence? What is the alternative? But in
Yeah.
joint replacements, you have great alternatives. and in other surgeries, you have great alternatives, and the incidence is not super low. So if it's cheap and easy, why not? Why not no?
Yeah. Um, you also mentioned, since you just mentioned titanium, I remember you saying that Skittles have titanium.
Ah!
Yeah. But
Everybody was
have
blown away.
I think they have a titanium dioxide, or they have something dioxide. They have a metal coating. It's not, not in Europe. In the U.S.,
Yeah,
it's a metal. It's on the outside. So I'm not as good at the nutrition side of metal allergies, but some people really don't love it. I'm just gonna look right now. What metal is in Skittles, just so I don't get it wrong. Let's see. Titanium dioxide. Yep, it's titanium dioxide. So that's the coating to make them shiny and crunchy.
yeah,
Kind of crazy, like,
Crazy.
so,
just nutty. But a lot of people are worried about nutrition with the metals in your nutrition too. It's sort of out of my area of implants, so I don't want to go there. But the allergists I've talked to are starting to think about that as well.
sure. Yeah, we don't need to dig into too much, but I imagine if I'm a person who flags, I got one of your Sensi bands on right now. I've been going through the metals. If I flag for titanium, I probably will stop eating Skittles.
I would,
Not that I eat a
I
lot of
would
Skittles in
suggest
the first
that.
place, but I like Skittles, and but I
Yeah.
would just not eat them at all if I saw that I was having a significant immune response to them.
Yeah, fortunately, titanium is a pretty low incidence of immune response.
Ooh, thank
Yeah.
God.
But what once got me into this, if you just to divert, what really made me go all the way with Sensiband, I've been worried about allergies for quite a while, and I've
Yeah.
been thinking about it. What do we do? We need to find a way to test people. But
Mm,
then I operated on a nurse, and I had done a cervical fusion on her like 10 years ago before we had disc replacement. She had a good result for 10 years, but then the next level wore out, which is what you worry about with fusion.
yeah.
So she had a titanium plate in there, but I took it out and I converted the next level to a disc replacement, which had cobalt and chrome in it. And she did great for about a week. Arm pain gone, typical happy result. And then her whole body started having rashes, really bad. She was losing it. I sent her to allergists, immunologists. Ultimately, she was found out to have a cobalt allergy. And she was on high dose steroids. We tried everything. She begged me, she said, please just take this thing out of me. So 6 weeks after surgery, I agreed to take it out. And I was worried that I thought maybe she had a new pesticide in her house or new laundry detergent, and I'm going to take this thing out of her neck. So I took it out of her neck and replaced it with a fusion with a same type of titanium plate that I knew she tolerated, and everything went away. So that made me really say, holy cow, there's a subset of people that are very reactive. And I've been hearing that, but I hadn't seen it. And, she literally, everything went away. And she's great. This is 7 or 8 years ago. She's fine.
Yeah.
So it's and there's a subset of people that are very reactive. And then there's a lot of people that are non-reactors, just like we know some people are sensitive to their environment and other people are
Yeah.
not as sensitive.
Mhm.
When it comes to surgery, though, if somebody has this reaction, is there best remedy for this, depending upon the kind of the severity of that reaction, to have another surgery and replace that? Because that seems like
Yeah,
the
no,
most
I've been,
invasive.
that's a great question. I've been in practice 27 years. Once I've had to do that. So,
Yeah,
no, most people have a much, much lower grade reaction. And I'm not saying to take it out. I'm really saying ideally you identify beforehand. Go, test yourself beforehand because your doctor's not going to do it for you in most
yeah,
cases. Some doctors are getting it. Like once you know about metal allergies, it's so obvious. Like if you're reacting on your skin, you don't want to put in you forever. Um, but if, test yourself and go to your doctor. Say, hey, listen, I react to chrome. Please don't use a chrome implant. And then they won't. If you already have it in you and you're having some response, the answer is, now you have an answer. You know why you're reacting, and don't get that put in another place. If you're in a small subset of people where the reaction is so bad and you just really can't take it, then you have to weigh the risks and benefits of a revision. But that is not the knee-jerk response. Most people ride it out. It's not. It's kind of like Doug. His shoulder isn't perfect. That's probably not an allergy. There's a small chance, but it probably might just be how surgery ended up.
yeah,
But if it is an allergy, I wouldn't mess with it for what you're feeling. It's too risky to go in there and mess with your shoulder unless it was just a freebie to take out one screw or something.
yeah,
So in general, you're kind of stuck once you've had the surgery, unless it's a very bad reaction. But just knowing what's bothering you, instead of the surgeon telling you you're depressed, you say, I know the reason I feel crappy is I have low grade inflammation because I'm reacting to nickel that you put in me.
yeah. I can imagine the frustration that would be too. One, not knowing, but um, like any allergic reaction, just even if it's like a seasonal allergies, you're like, my nose is running. When it's inside your body, what are you going to do? Like itch it away? You can't like scratch it, like that. That would be the most frustrating thing. You're like, no, it's in me. I can feel it. Like this is bothering me. And someone's like, I don't know.
No,
And
and you're making a point. Plus, you're inflamed, and that's
yeah,
probably not good for you. Like I have friends in cardiology, and since we're just on the edge of learning this, we'd love to do some bigger studies looking at inflammatory factors because they do lead to coronary artery disease and other things. So it's probably not healthy to just sort of always have some inflammation. But
yeah.
yeah,
Just it just eats at your immune system for, call it 3-4% a day, but over time that compounds and it just
it chips away. And
anytime
we don't have
something else
data.
comes up.
Yeah, I don't have data on that yet, but it's sort of intuitive that you probably don't want to be inflamed.
Yeah, are you guys doing any kind of more comprehensive studies into this?
Yeah, no, that's a good. So we are FDA registered, meaning we're safe. FDA knows about our device, and it's we manufacture according to strict FDA criteria. We are now doing some trials. We have a surgeon named Dr. Sa, Alexander Sa in California, does over 1,000 joint replacements a year. He's looking at our tests versus skin patch testing and lymphocyte transformation testing. He's going to look at the rate of. There already is some data showing the rate of allergies in patients that have a failed implant are much higher than the normal population. So some of them probably are from allergies, like the implant has
Yeah.
failed, and we know they're much more likely to be allergic. So we're doing some studies, but the problem is I have a day job. I'm a spine surgeon, and it's kind of tough. But once we get some traction and we have the funding needed, we could start to hire staff and look at bigger studies because we do want to we want to push forward the science in allergies because right now with the Sensiband test, some people are claiming,
Yeah.
oh, the skin is not as good as testing internally. The
Mm.
truth is, allergists use skin patch testing. Like they're the experts. And what test do they use? Skin patch. They don't say no, skin doesn't matter. So when surgeons say to me, I don't think skin matters, I say to them, well, do you think it's a different immune system? It's the same immune system, the same T cells. They migrate. But the industry has tried to say, oh, skin patch testing is not that helpful, and they're trying to denigrate. And again, we
Yeah.
need more science. I don't want to say they're totally wrong to just question, but on the other hand, if you don't have data, you probably should err on the side of caution as opposed to err on the side of just keep doing what you're doing and not care.
Yeah. I think anytime most people are telling you you're wrong, you're doing a great job. That
Yeah,
just means
it's
you're
probably
thinking
good.
outside the box and you probably have something that's like poking holes in a narrative that needs to have holes poked in it. And I I feel like anytime someone's like making a broad generalization of like you should do all like hold on a second. What about for me? I don't want to hear like the whole country should do this. I want to know what I should do. And if you send somebody your product and it has 8 different things to test for, um, there's a decent chance, especially with the overall health of people, that there's going to be some sort of inflammation, some sort of reaction to one of those things, and it at least arms the people to be advocates for themselves to go in and say, can we at least pay attention to this?
Yeah, no, that I think that's what we're trying to do. And the kits might be, we have 7 metals in them now. But that's a little bit overwhelming, I think, for some people. We might make some smaller kits because most people, if you're going for regular surgery, you probably don't need to test for titanium and aluminum. We want to pare it down because we don't want we want to make it an easier soundbite for people to handle. If you're going to considering a joint replacement, maybe just test these four. If you're considering, trauma surgery, just do these
Yeah,
three. Like, we're trying to simplify it so that people don't have to, because, wearing 7 different bands might just be a little overwhelming for some people we want to make it more approachable. But yeah, we want to empower the patients so they know what the right implant is for them. And my partner, he's concerned because when you get a stent in your heart, when you have coronary artery disease, those stents, most of them contain nickel. It's called nitinol. It's a metal with nickel in it.
Mm.
And they do make titanium versions of that, which would be less allergic. So we don't have data yet, but it makes sense to me. If you react to nickel, I don't know if you want it in your coronary arteries. It may not be as effective. So again, this is an example where we just need data, and it's going to be expensive and difficult, but maybe with AI, we're going to be able to drill through some of this. Because Anders, like you said, what you'll look at is a giant study that says something doesn't work because it's the effects are canceling out amongst various subsets of patients, and you really have
yeah.
to drill down to find which subset to get the right information out of them.
Well, if I was about to go have a surgery and you showed me some of the after pictures of people and their allergies to specific metals, I would be wearing all of the bands to make sure that I was not about to put something in my body that was going to cause that much. I mean, it looked like some people were having like actual like holes like burned into their body, not maybe not that aggressive, but the inflammation, like it looks like it almost like bubbles up on the skin. And I couldn't imagine somebody like that going in and actually having that permanently implanted into their body. Like you talk about the immune system and the inflammation, that's guaranteed to happen. And it may not be 1, 2, 3% of an inconvenience. But those people, it could be 15, 20% of an inconvenience on a daily basis and irritable. Some people have like from the pictures you showed, like that's a serious thing that people need to know about.
No, I agree with you. Once people see the reactions, you get it. Whenever someone says, I don't think it's a big deal, I say, well, look what nickel does to this woman's skin in 3 days. Do you think you should put that in her body? And it just passes the smell test. It's completely obvious that you shouldn't do that. So while I don't have data on, 50,000 joint replacements and drilling down into swelling and inflammation and revision, and, we kind of, it's obvious that you just don't want that put in your body.
Yeah.
Especially when there's a good alternative. Like, why not just say, hey, you know what? Use the one that doesn't have that.
Yeah.
Sure. So in your mind, what is best case scenario for surgery prep for this category, in the next 5, 10 years here?
Yeah, I mean, I think the best case would be, I think once patients start doing this and going to their surgeon and saying, hey, before I get my knee replacement, my hip replacement, know that I'm cobalt allergic. I think surgeons will then start to say, hey, you know what? I got to get on board with this. Because right now, surgeons just don't want to spend the time because it's not a 1 minute conversation. You have to explain to people, and some people who are on the cusp, say your knees bothering you, you may need a knee replacement, and then you hear, oh, you could be allergic to the metal. You may say, I'll hold off for a few more years, and surgeons don't like that. They want to get their procedure done. So ideally, we're marketing now to the public. We realize that some surgeons are adopting this, but a lot are they just got too many plates in the air. They just can't do it. So we want the public to know about this. And I think before you get a surgery, you should ask the surgeon, what are you going to be putting in me? And then just test yourself to those metals and go back to them and say, I know you're planning to use a nickel containing implant, but I'm nickel allergic. Can you use something different? And I need a good surgeon will say, yeah. Now, some surgeons say, nope, I only know how to use this one. And that probably tells you something about them. You probably want to then find somebody who can get you the right implant. And then other people will say, well, should I also do the LTT test or do the skin patch test? We don't know which of these is superior, but I know if I react to something, I wouldn't say, well, I did the blood test and it said it's okay and put it in my body. I think if any one of those is positive, I'm going to err on the side of don't put it inside of me. But our goal would be to empower patients, get people before they have surgery or people that are having a poor outcome from surgery to test themselves and not to revise the implant, but just to have an answer and know not to get it again. And then over time, we'd love it if it was just part of the surgical protocol to test people, at least for the most common metals, nickel and chrome and cobalt, and tailor the implant to them so that we'll see less failures and better overall outcomes.
Yeah. Yeah, absolutely. I mean, and just for the audience, like we get no financial benefit from talking about this. We just met in New Jersey here a couple weeks back, and you were talking about it. And again, me having my mom my entire life, knowing that having seen her reacting to metals, just wearing a necklace or whatever it was, that really caught my eye when you were talking about this. And also thinking I'm probably going to end up with a joint replacement at some point in my life, and I figured I should be on board with this from day one. And I'm wearing one right now. Of course, I've gone through a handful of metals, haven't reacted to anything yet, but I figured since I very likely would have some metal in my body at some point, that it would be wise for me to jump on this, as convenient as it is, just basically to wear a watch for a couple weeks to figure out if metal is going to cause a problem for many years in a row. Might as well just knock it out.
No, you're smart. You're smart because also, say you have an accident and you break a bone. Unfortunately, you're not allergic. But if you were reacting to chrome or nickel, you could say, I'm nickel allergic or chrome allergic, and they'll use a titanium plate. It's right there, or titanium a rod. So you're ahead of the curve. But most people are not going to react, and that's good information to have too. You say, hey, listen, I'm not. We're looking at testing the military. So we've had some meetings with the military and testing soldiers ahead of time, so that if they get injured in battle, they'll know what's right for them. So the military. We've had to reconfigure the kit. Everything has to be made in America. So we're doing it. It's gonna, we're hopefully gonna get that accomplished. But they're looking hard at us because they see the value.
Yeah, Dr. Reiter, this has been fantastic, man. It was great meeting you in New Jersey, and as soon as you started talking about this, I was like, I did that thing. I was like, stop talking. I want it to sound authentic. We got to get you on the podcast so we can do a full hour. So I appreciate you taking the time to come on today and tell everybody kind of what you're working on here. If they are interested, where can they find you, Sensiband, kind of all the outlets that you have?
Yeah, perfect. So, right now we're available on Amazon and Shopify, and we're going to be on Walmart's online store, very soon. We've had meetings with Walgreens and CVS, but we're not there yet. So right now, probably those, if you just Google Sensiband, Amazon or Shopify are probably the easiest ways to get a hold of it. And listen, I really appreciate you guys having me because what you're doing is great. You guys are forward thinkers. You want to preemptively catch problems, and that's what you're all about. So I'm so glad you see the value in this as well.
Absolutely. And we'll put a link down in the show notes as well. So make sure you check that out if you're interested. Doug Larson.
You bet. I am on Instagram, Douglas C. Larson. Dr. Reiter, appreciate you coming on the show. I think you're onto something very cool here. You also, of course, are a forward thinker, and not many people are talking about this. So I think you're doing good work here. So appreciate you being here.
All right, thank you so much. I really enjoyed doing this, and thanks for having me.
I'm Anders Varner at Anders Varner, and we are Barbell Shrugged, Barbell_Shrugged. And make sure you get over to rapidhealthreport.com. That is where Dan Garner and Dr. Andy Galpin are doing a free lab, lifestyle, and performance analysis. And you can access that at rapidhealthreport.com. Friends, we'll see you guys next week.